Obamacare now is exposed to be a complete fraud. The reason why Obamacare seemed like it may work is because there were subsidies. The government paid a lot into it to make it look like it's not as expensive as it is.
I was taught to be a good human, work hard, get a salary, and be of service to people.
Most people who go into medicine are like, I want to help people, and they figure out what they want to do. It's okay to say, you know what, I wanted to be a surgeon because I think that's the coolest thing in the world.
I'm going to pull a banner. I even have the idea of it's going to be a leg and then the banner cuts up at the ankle. If you want to see the rest of his leg, call us.
The baker doesn't make bread for you to have bread. He makes bread because he values the money that you're going to pay him for it. And the truth is, the world is a better place because the baker makes bread.
Two vascular surgeons walk into a bar and come out with a podcast. We are talking everything vascular and not. Welcome to the Life of Flow podcast.
Ronan, welcome to the Life of Flow podcast. Sorry, my co-host Miguel got stuck doing cases today, so he won't be able to join us, but I think we'll do fine. We'll have him in spirit.
That's a good reason not to be here.
I know. Ronan, were you my chief at some point?
I think so. I don't remember how many years apart we were. I don't know if I was a 5 and you were a 3 or something like that. We didn't have too many years between us, but I have fond memories of residency.
Yeah, me too. I wonder how many times I fucked up in your service.
The truth is, I think I was very hard on everybody. I remember, I forget her name, but there was one resident who had a really hard time in the service because of the way I ran things.
Yeah.
And, I felt really bad because, I was very hard on her. But then she emailed me a year or two later, I think maybe when she was in fellowship, and she thanked me. And she was like, hey, I just want you to know that I really think that I didn't appreciate your approach at the time, but now that I'm out and I'm in a different place, I see the value of what you did. And I felt that was the nicest thing. And it allowed me to also learn that you have to give that kind of feedback to people. If you think that way, I learned, and what I did with my, with people that I've interacted with, I use that also where, if I felt a certain way that was different than when I interacted with somebody, I think it's important to reach back out. You might think it, and that's good, but it's really better to reach out to that person and say, hey, I really appreciate what you did. Even if it's years later, people like that kind of stuff. And I thought that was very cool.
That's awesome. Ronan, I never really learned much about you. Tell me a little bit about you. Where did you grow up?
So I was born in Israel. I moved to the United States when I was 9 years old. I actually didn't speak a word of English when I first came here. I think I took English lessons for a couple months before I moved to the United States. I moved to Florida, and then at 18, I moved to New York for college, and I stayed in New York for 12 years. That's where I did college. I actually went to grad school before medical school. I didn't think I was going to be a doctor.
What did you go to grad school for?
Biomedical engineering. And that was sort of the transition into medicine, right? So I really was more analytical. I liked math and physics and that kind of stuff. I loved that. And when I went to grad school, I had to take anatomy with the medical students. And that was so hard because I didn't even take a bio course going into that, course. So I didn't really understand the language at all. I didn't know. I remember he was talking about fascia and this and that. And I was like, what the hell is that? And it was very hard, but it kind of drove me. It made me think okay, you know what? I really think I like this medical thing. At first I thought that I would go to medical. This sounds ridiculous, but my parents were very supportive of me learning, but I wanted to go to medical school to be an excellent biomedical engineer, right? To know enough and to know but to know enough about medicine.
Don't do that, kid.
To know as much about medicine as a doctor, right? Yeah. But very quickly I was like, you know what? I think there's going to be more mobility as a doctor. There's more flexibility. I could do a lot more. So very quickly I was like, you know what? I think I'm going to be a doctor. And the transition to surgery was it just made sense because for an engineer, I'm sure you feel the same way. Surgery is like engineering basically, right? fluid dynamics, and things have to flow a certain way, and things have to be connected correctly. And if they're not, like, it's just not going to work. Right. So
I
it's very
I look at
technical.
it yeah, but I look at it more like art.
Okay.
Yeah,
To
yeah.
each his own, but
Yeah,
it's interesting.
yeah,
Right. So like, I don't know what your background is. Maybe you have a background in that, but to me, it's engineering. Like, to me,
yeah.
I constantly think of engineering when I look at the human body.
Yeah, what
So,
especially
yeah, so then I went to medical school, and I did my first 2 years of residency at Montefiore, and I was a prelim, so it was very tough. I'm sure you can imagine, like, a prelim in New York also, which,
Jesus Christ, yeah.
I felt like, we were treated like we were a dime a dozen. Like, okay, if you don't want, to stay here, like, there's 1,000 other people that would take this spot.
Yeah.
And they had a categorical spot for me, but it would have meant for me to repeat my second year.
Mhm.
And so I kind of reached out to multiple programs, and um, uh, one of them was Temple, and Temple reached out and they said, "Hey, we have a third year spot." And I came in as a third year, not losing any time. And it was just an amazing transition because it was such a different environment than New York. Um,
Really?
However, the trauma experience was completely different. Like, I came from the Bronx, and I thought that was busy in trauma. And I remember my first night on call in Temple, and
North
I
Philly.
called my wife in the morning, and I was like, "Man, the Bronx was Disneyland compared to North Philly."
Yeah, North Philly were crazy. How was it different? How was the residency experience different?
It was much less, oh man, malignant, I would say. I don't want to say anything bad about Montefiore. The truth is, like, I think I got a great education there. I really learned, but it was almost like learning by fire, right? Like, you're just
Mhm,
thrown into it. Like, I remember being a second year resident, right, where you're the consult resident, and
mhm.
like on a Friday night, like, the ER was just packed. Like, it's almost like that was like the thing to do in the Bronx, was go to the ER and be admitted as a patient. There were beds, like, lined up,
Yeah.
like 4 deep. Like, how can you do, like, a rectal exam when there's no curtains and whatever? And I remember, like, just starting my shift, right? Everybody leaves the hospital, and you're all of a sudden all alone at night, and you're like, "Okay, I have 6 consults, and I'm, like, all alone."
Yeah.
And that's kinda how you had to learn. And, like, I had a good chief. They were also very strict, um, which didn't translate well when I transferred, because I felt like I was hard on other residents also. But, like, I'll give you an
Yeah.
example. I had a chief when I was in, New York. There was one day, I think I was like, I must have been a first or second year, obviously, right? So, like, it was one of those 2 years. So I was pretty, like, low on the totem pole. And there were maybe a few other interns on the team, and we had to be prepared for evening report or evening rounds. And we didn't have our shit together. Okay, I don't know if I'm allowed to
Yeah,
curse, but
yeah, yeah.
we didn't have our shit together at 6
Yeah.
p.m. Right? Like, the list wasn't ready. Like, we didn't have results, something like that. And he walks in, and we don't have our stuff together, and he's like, "All right, I'm gonna go home, and I'm gonna come back at some point, and you guys just better be ready." And he didn't tell us when he was gonna come back, you know? So it's like we're all just, like, waiting, right? Like, we have to make sure that we're, like, 100%. And
Yeah.
that was, like, a very old school mentality, right? Because
Yeah.
it was that kind of program. But this was back in, 2009, right? So, like, other programs, like when I went to Temple, it was a completely different experience. Like, people were nice to the residents were nice to each other. Like, again, it was just a different experience. And I do think the first 2 years made me a really good resident. I really feel like I got a great education. My my second year, like I said, was I was a consult resident. I learned a ton being a
Mhm.
consult resident, right? Where you basically don't go to the OR, you just see and diagnose, right? All day long.
Yeah.
Um, and that was key. That was formative. But the social environment is, I think, where things were very different in New York versus Temple. At Temple, it was like, okay, I'm like treated a little nicer than in New York. And it was like a family, right? So like you remember Amy Goldberg, like, she made the program like a family. And I don't know if you had that experience, but I to this day, like, we're a family.
Yeah, to this day, we have, like, group chats. We, like, try to get together. It's difficult to get together, but yeah, it was, I still think it was tough. It was tougher than anything I've ever done. It's tougher than where I taught after I left training. But still,
Where
like, that
where was that?
family. UT
Where
San
did
Antonio UT San
Oh,
Antonio, UT.
really? Okay.
Yeah.
Okay.
Yeah,
I'm
so
surprised.
Miguel, he's
Hey, Miguel.
cameo appearance. I love it.
Hey,
I'll be doing this throughout the day.
Let's do it.
that
Let's
that looks
go.
good. I
Yeah.
like it.
Miguel,
Yeah. I
you
wanted
have
to meet you, Miguel, so I'm glad you're on.
yeah.
I'm here, brother.
I'm not gonna go whole into it, but we were talking about residency. We are reminiscing about residency in the Northeast. But let's
There's
pivot.
nothing too reminiscent in that.
There's a lot to
North.
reminisce. I
Yeah,
remember,
but
like, yeah. Do you remember that bar that you could see from the ICU MySpace bar?
no, because I went nowhere around the hospital. I did not
No,
want
no,
to
it was
walk out.
in the top in the ICU. No, no, obviously I didn't
Okay.
go out there either.
Oh,
But
okay.
if you went to the corner room in the ICU, you could see down, and there was that bar, MySpace bar,
Okay.
and you don't remember? We would hear gunshots, and then we would all go there and see, and there were people, like, hobbling out of MySpace bar, shot, walking into the ED.
No, I don't
There's
remember.
something to reminisce.
The
Yeah.
one thing I remember is the Chinese restaurant on the other side of the hospital where like where residents would get held up by gunpoint. And I was
Just for
like,
Chinese
I'm
food.
never getting anything from
Yeah.
there.
I might have done that a couple times.
Yeah.
But yeah. So Ronan, talk to us about ACEs. And
So
when did
Ace
that
is yeah.
yeah, give us a little origin story.
All right. So it's actually very interesting because ACEs as an entity has been around for a very long time. So kind of tell you the thoughts behind it. So when I finished fellowship in 2014, I don't know what it is now. I think it's August 1st that they finished, but back then we finished July 1st and I wasn't starting my full-time job until September because I wanted some time off. But obviously I had to make a living to pay for our living expenses. So when I was in fellowship, I applied to do locums for those couple months. And so for like July and August, I did locums. And the first month that I basically went for like a week somewhere. And it was actually the middle of nowhere, Pennsylvania, related to UPMC, but that has nothing to do with like where I work now. Um, and the first time I went there, I took a train from Connecticut to the middle of nowhere, Pennsylvania. It took me like 9 hours and two switches to different trains. It was the biggest pain in the ass. I was like, man, I can't do this. Like, that's time that you're not getting paid, right? Also, so that adds like 2 days to your shift, and I was already away from home for that long. Now, I had a pilot's license that I got back in 1999, and then I did more flying and ratings in medical school. And I kind of wanted to get back into it also, but I never thought that I would be able to put the two together. But what I did the second time that I went to like the local flight school and I was like, hey, this is my situation. I want to start taking lessons. I got to get to this place. Can I go with an instructor? So we arranged something where I flew with an instructor. On the way there. We kind of, like cleaned the rust off, um, you know, used it as flying lessons. And then the instructor flew back alone. And then the instructor flew back alone to pick me up. And we would fly again on the way back and do more lessons. And then in between, I would also take lessons. So very quickly, I kind of regained my skills enough to be able to fly alone. And I kept doing that with instructors for like 4 or 5 more months, basically till December. And even when I had a full-time job, um, I just felt like I wanted to do a lot more than I was doing. You finish fellowship, you're working. I went to shock trauma, so I was working like 120 hours a week, and all of a sudden you're an attending and you work like 50 hours a week, and you're like, man, this is like nothing. I can do so much more, and you want to operate, right? And I really enjoyed a lot of the things about traveling for work, like just seeing how different systems work and like what works at this hospital versus that hospital. What do they have in common? How are they dissimilar? What can I take from one hospital and bring to another? Like it just made me think of like the different systems. Um, and I also liked making my own schedule and I felt appreciated. Like you go to these small hospitals where they really need a surgeon. So there were a lot of benefits to doing that. So because I had the time, I just kept doing locums, even with a full time job, like 3 or 4 days a month. And what that allowed me to do was also like that extra money allowed me to buy my first airplane, which was in 2014. Right. So like my wife and I were kind of like, okay, so the money from the full time job is
What
like
airplane did you buy?
a Cirrus SR-22, a 4-seat piston. And
How old was it?
it was a 2004 and I bought it in
Because nobody
2014.
buys a new plane, right? Nobody buys a new plane.
Uh,
Everybody buys.
if you make a lot of money in business, you buy a new plane for the deduction. Otherwise,
Got it.
yeah, because it's like a boat. It depreciates, a lot like the second you fly it away. So it's not,
Yeah.
unless you're making millions of dollars, you don't buy a new plane.
How much does the plane cost?
I can't even say on, let's just say it's like a small house.
I've seen it. Yeah, I've
You
looked into this, by the way.
Are you
I didn't know we're gonna go into this, but I'm so happy because when I have clinics in Victoria, that's 2-hour flight. I'm sorry, 2-hour drive. Um, Anywhere from about 250 to 350,000 gets you a used decent plane.
are
Oh
you
yeah.
gonna
I mean,
fly it?
you can even get one for less. But
Okay.
but for that money, you can get something pretty capable actually. Like we should talk
Yeah,
offline. I'll tell you all about it. I just
no,
don't
let's talk
like
about it
Are you
I
online.
gonna
just don't
brand
like
it, Hope? Are you gonna brand it?
Yeah, man, I'm gonna pull a banner.
Yeah.
I'm gonna fucking pull a banner.
Have you
Perfect.
ever taken flying lessons?
I even have the idea of the banner. It's gonna be a leg, and then the banner cuts up at the ankle, and then it's like, if you want to see the rest of this leg, call us. You know?
You could do like formation flying and have the other half of the banner, you know.
Yeah, yeah,
All right.
yeah.
Yeah.
Cool. Have you
Anyway,
taken any flying lessons, Miguel?
no, but I'm looking for somebody there, and there's like private guys that do lessons here. So there's a few. I know at least 2 doctors that fly to a lot of these remote places. You know, Texas is so expansive that it is a really it's a really smart model of having these remote clinics that you can go to relatively quickly. Um,
So
and
that's
it doesn't
that's what
even
I
need to be
basically
tied to
do.
a hospital, right? It doesn't even need to be tied to a hospital because in my model is I actually want to be away from the hospitals. But you know, you can create outpatient units of care for at least vascular care in the communities where you can have nurse practitioners on site, and then you fly in when you have to do cases because that's the return on investment of my time is I don't want to be doing clinic. I need to be doing cases. Like that's where the margin is. And so if you can envision a time in your life where you're doing, you know, every week or every 2 weeks, you're flying for a different place and then you're creating a certain amount of volume there, but it doesn't sustain a full time, that's fine because you can just fly in there when you need to. And then you know, bulk load these cases for front. But anyway,
So that I mean,
that
essentially, that's what ACEs does, right? Like I was going to get to that part of the story, but essentially, that's what we do. So like we perform outpatient surgeries at ASCs in various locations where we also like we line up surgeries over 2 days. We fly in, we do the surgeries, and we fly out, right? And we do exactly the same. And most of the stuff, I mean, I don't know what it's like in vascular surgery in terms of what you need pre-op and post-op, but at least in general surgery, most of the stuff, like, the physical exam is such a poor, you know, thing. It has like very poor inter-rater reliability. We have such high definition imaging. Most of the things that I see are hernias. You can diagnose it and kind of decide what the plan is with a CAT scan. So all that stuff could be done remotely. And I just need to really see you and operate in person, and everything else can be done remotely. So that's kind of what we've done. And I want to make it into a,
is your interrupt is your if your infrastructure is one that you have a local provider on site that can work up the patient, get the imaging,
You don't
get
even need
the
that.
H
You don't even need that. You can arrange for imaging remotely. I have an admin who does that for me. You know, it basically like I have like a virtual office administrator, right? That hey, we got a consult for a hernia. All right, that needs a CAT scan. Let's arrange for that locally to that patient.
To the
And not
care
only that, but what we're doing, the 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 catch here in terms of what we're doing is it's a cash pay practice. So we don't even deal with insurance. So this is where the model is a little unique. So have you guys heard of the Surgery Center of Oklahoma?
No.
Yes.
Yeah. So you're familiar with the model? So it's basically you can go on their website and there's like a menu of surgeries and the prices, the all-in cash price, where you're not going to get surprise billing, like you're not going to get an anesthesia bill 3 months later. You pay up front. This is geared mostly towards self-funded employers, right? So like employers are sick and tired of like paying premiums for their employees every year. It goes up 30% every year. That money pretty much goes nowhere. And they pay insane amounts of money. Even the patient then still has to pay a lot of money because they're not really covered, right? Because they have a high deductible or out of pocket or whatever. So the cost of care is so high that, what if you want to get something done at Surgery Center of Oklahoma, it's like a fraction of the cost of what it would be charged or what it would cost you if you were to go through insurance. So there's like a couple places around the United
Okay.
States that do this.
You're removing the insurance out of your algorithm.
Correct, correct. But
Okay.
I do something else that's different than the Surgery Center of Oklahoma. So the Surgery Center of Oklahoma and every one of their, um, I don't mean this in a bad way, but everyone who like copied that model, which it's a great model, and for people who are really principled in terms of like understanding where the problems with healthcare lie, which is the insurance problem, the insurance model. There's probably like a handful of brick and mortar ASCs that have gone towards this model. And I think that nowadays in Washington, there's a lot of chatter about, this kind of healthcare delivery, not specifically for surgery, but even direct primary care and insurance being truly what insurance is meant to be, which is catastrophic. So there's like a handful of brick and mortar places around the United States. We're the only virtual practice. We're like, okay, you know what? We figured rather than this being a hardware problem where I need to build another ASC in X location, there's already tons and tons of ASCs that are not at capacity. Why don't we partner with these ASCs and say, hey, we're going to come to your facility. We want to do these surgeries there. We're going to pay you for the facility, by the hour, by the procedure, whatever it is, and bring patients to your location to fill the gaps. And so we're like a software solution based on the Surgery Center of Oklahoma model. And the ability to fly to these places allows me to really set up shop anywhere, right? So that's been the real catch here, right? I can basically just go anywhere and be wherever I want to be.
Do you have an idea of your ballpark average age of your customer?
Based on a few months of data, I would say probably in their 50s.
Yeah.
So
And
So that's
for
this
general, yeah, go ahead.
huge difference thing from what our model can accomplish. We could probably very well do that in the venous world, for varicose veins, because there's going to be a shit ton of uninsured patients that want to take care of it. And you can absolutely come up with a cash price that makes sense for them. Um, Hell, if you think about efficiency, I'd rather do 4 segments with the same radio frequency catheter at the same time. But when we do that with an insurance, we have the patient come back 4 times because otherwise we get dinged 50% every other segment we do on the same procedure.
Right.
So
It doesn't
it's
make sense.
delayed.
Yeah.
Delayed. Of course, it's
Yeah.
dumb.
Yeah.
It's the dumbest thing in the world. And you could find that could be a model. Now, the problem, I would say, for another subsegment of at least what we do is that arterial patients, I'd say my average patient is going to be 85 years old. And those are all probably Medicare, Medicaid patients. And they're not going to have the capacity to come up and say, hey, here's $5,000 for a procedure. And by the way, I may need this procedure twice a year or once every other year for assisted primary patency. And so that's where the model, I think, if we were talking to our, to the normal people that follow us, I think this is great to get your serotonin going and thinking about maybe hybrid models, right? Because there's no reason why you couldn't have a cash. Here's what I actually would advise everybody out there: do this. Have a PLLC that carries contracts with insurance carriers. Have another PLLC that has no contracts whatsoever. And then you can have a third PLLC that actually does cash price. But then that allows you to funnel, depending on the circumstance, what particular care pathway you want to do with each one of those patients that helps them the most. That's the thing, is like, yes, of course, we're smart and we're trying to create margin, but the reality is that this is a service for patients. Patients need this. They want this. They don't have any other options than this. So, I mean, I think I think it's brilliant, Ron, and what you're
Yeah.
doing.
Yeah. No, it makes sense. But, I think, again, this goes back to, you're looking at it from the point of view of like the service to the patient, which obviously we want to take good care of patients. I'm looking at from it from the lens of like, I want to change the healthcare landscape, right? Like I think that using insurance for healthcare for routine things is the worst way to pay for anything. And I'm sure you would agree. And so
Can
this
you
is
break
not my
down that?
full-time practice.
Can
Yeah,
you
go ahead.
break down, because I know you've thought about this for a long time. When
Yeah.
we talked about you coming on, you talked about your grand rounds and how that was
Yeah. I
that was
pissed
a
off
whole
a lot of
routine.
people. Yeah, when I was a chief resident, it was right around the time that Obamacare came out, and it was like,
In the
and
Northeast.
I was
Yeah,
like devouring books. I don't know, like we were at Gene's Hospital. I think I was like a fourth year chief, and
yeah,
I read Atlas Shrugged like all day long at that rotation. I have Atlas Shrugged literally like tabbed with like 100 tabs of like quotes that I wanted to like remember. Anyway,
yeah.
so I was like devouring healthcare economics books like Basic Economics by Thomas Sowell, Free to Choose by Milton Friedman, The Road to Serfdom by Friedrich Hayek. Like these are all people that if you're interested in healthcare economics, I say is an absolute must read. So for my chief grand rounds, I basically gave a talk, and I cleverly named it "The Elephant in the Room," why big government is bad for your health. And I ruffled a lot of feathers because there were a lot of people who thought Obamacare was the greatest thing since sliced bread. And I think now in 2026, we know like there's nobody that can say that Obamacare was a success. And that's why I think the business is ripe for the taking now, because this is now when change is coming to healthcare, right? And like I was saying before you came on, Miguel, people are already talking about this in Washington, meaning I agree with you that your patient population is Medicare, Medicaid. That's not going to change for a while, but I believe Medicare, Medicaid will change. Like it'll be a different type of system because it's not sustainable, right? You can't pay the doctors what they're paying. More and more doctors are not accepting it because they're like this is not worth it, right? And so you want to have the patient be taken care of, but you don't have the people providing the care wanting to play that game. And so there's got to be a change. And I think with the current administration, with the current people in the healthcare roles, with people, even Mark Cuban is talking about this kind of model, right? So like pop culture is talking about it. And I think that within the next 10 to 15 years, we're going to go back to the old ways that we did it. But right now, it's very simple. Healthcare, let's say a surgery or a service like going to see your doctor for the annual visit costs a certain amount of money, X, whatever it is. I don't care. It doesn't really matter. If you add an administrative burden of if you add an administrative burden of insurance to that, there's no way that it's going to be any less. You can't make anything cheaper by paying through insurance. That doesn't make sense. If you think it's cheaper, you don't understand that you're basically redistributing money and adding a cost, because somebody's going to have to file your claim. Somebody's got to have to code it. Somebody's going to have to check the code. And how do all these people like make money? They're not working for free. So now, so in my model, we take all that stuff out. We say, look, we want to get physicians to be independent and reduce the cost of care and take out all the middlemen. I don't have anybody telling me, hey, you can't do the surgery. You need pre-authorization, right? And like, so the whole insurance business, patients hate it because they don't feel like they're getting what they should be getting for what they're paying. Doctors hate it because it causes the biggest headache. And I'm a true believer that, all this talk that you see on social media and in all the, journals, right? All the fancy journals talking about burnout. Burnout is not because we're working 20-hour days. We'll work 20-hour days till the day we
Burnout is not
die.
because of surgery.
Right. Like we
We
worked
fucking
like
love it.
our asses off. We worked our asses off to get here. Like we're hard workers. The reason why we're burnt out is because 90% of my time is spent answering administrative emails like, hey, does this patient qualify for inpatient stay? If not, do a peer-to-peer. Like, no, I'm not going to talk to some, family practice guy who doesn't know anything about trauma. Right. Like, I mean, that's ridiculous. So if you go back to true patient care, which is what this model does, the doctor likes it, the patients like it. They get like a white glove concierge medicine service. And I don't want people to be under the wrong impression that this is like only for the rich, right? This is not for the rich. Again, if your employer buys into this system, the employer will save millions of dollars on their healthcare costs. And
Wait,
and
can you
the
explain
the
how?
surg yeah. So right now, the employer. So when you have health insurance, your employer pays a large chunk of their of the premiums towards that health insurance, right? They build a health insurance product for their employees. Now, what happens is a lot of like small to medium sized businesses end up spending more money on healthcare than they spend on the materials for the stuff that they're building, right? Like, take I'll give you a big example, like a car company. Instead of paying for materials like steel and whatever it takes to build a car, they're paying a shit ton of money for their employees' healthcare. Now, I don't know if people know this, but every year that premium has gone up. And nowadays, again, going back to like how Obamacare now is exposed to be a complete fraud, the reason why Obamacare seemed like it may work is because there were subsidies, meaning like the government paid a lot into it to make it look like it's not as expensive as it is, right? Anyway, so employers end up paying like 30% more year over year, right? And they're shelling out millions and millions of dollars to healthcare. Not only that, don't forget, you also, not you yourself, but the employee has wages taken out towards healthcare, right? You choose what plan you want, and some of your wages go towards that premium. Then don't forget, when you go to get a procedure, you have an out of pocket, right? you you have a deductible, right? So you still have to pay even if you have insurance. Take all that money that you paid in and imagine you need a gallbladder surgery once in your life. How much did you end up actually paying for that gallbladder if you take what your employer paid, what you paid out of pocket, all that stuff, right? And you wasted a ton of money that you could have just saved elsewhere. So employers are saying, you know what, I'm going to be self-funded. I'm going to use something called like a third-party administrator to potentially build a different type of healthcare plan. I'm going to use direct primary care physicians, which is like concierge doctors. Patients love it. It's cheaper overall. I don't pay as much money and I get to keep and the employer says I get to keep more of that premium that I would have paid out. That money is actually going towards healthcare, not to administrative costs, right? Not to the broker, not to all the middlemen, right? Like, so everybody says how like what healthcare is what, like 20-25% of GDP. You know why that is? Because so when you have that, everybody looks at that as the shiny object and says, "I want a piece of it," right? So that's where all the brokers and the PBMs and all those people go in and say, "Okay, this is a big sector of the economy. I want my piece." But who's the only person creating value? Us, right? The doctors. Like we went to medical school. I know how to do the operation. What does anybody else along the chain add to the value of this equation. None. And this is why I think we have to go back to direct patient and doctor relationships, including financial. And it sounds bad. Like, you have this visceral feeling when you hear, oh, there's a direct relationship between doctor and patient. But why does it need to be a direct relationship, a financial relationship with an insurance? The insurance is not any more magnanimous or philanthropic than the doctor, right? The doctor
There
is
is absolutely nothing bad between exchange of money is energy and time. That's it. Money is just my energy and my time that I exchange to you for in this thing that we call dollars. So I think I completely disregard this notion that doctors shouldn't be yeah, completely involved in finances and be very transparent and open, and this is the service and this is what it costs. Everyone else does it. We've all This is how humanity has worked for millennia. We barter
right.
our time and our energy. But let's get the fuck over it.
Right. So, it's funny because, you know, we've created such a crazy system of paying for healthcare that you have committees like on national organizations having like finance committees and economics committees, and they sit around the table and they turn themselves into pretzels, trying to figure out how to solve the problem of the high cost of care. And they're like, well, let's look at quality and let's look at this. And I'm not I'm not saying quality is not an important factor, but I'm saying you and I both know there's an easy solution. Just pay for it directly, right? Like, go back to, like you said, how humans interact in every other field,
Yeah,
you know?
and especially
Eh,
now with how easy it is to communicate, like human interactions, which we call the market, takes care of it. Like, you rate your fucking doctor, have everything online, and then people will choose who they want. And
Right. And
they
also,
people
like,
people people always have their best interest at heart. Nobody's gonna care more about the patient than the patient and the family and then the doctor. So
right. And this is where, when I was talking about healthcare economics and all the books that I mentioned, this is where it's very important for doctors to understand basic economics. And they also have to understand that economics does not equal finance. It's two very different things. Um, So economics involves psychology and human behavior and decision making and alternative uses of materials and goods and all that stuff, right? Like, how do you make a decision when you have multiple choices? Now, um, the reason I bring that up is because even value, you can't value something for somebody else. So you can't say this is more valuable than this. I'm a big proponent of the what's called the Austrian School of Economics, where it's the subjective nature of value. Value is subjective. So, for example, if a person, this is where it comes into medicine and where I come in. If a person wants to choose their surgery based on a location, not just the surgeon. I want to choose a surgeon, but I also, you know what? I want to go to South Carolina to have my surgery, and and I have that choice versus Oklahoma City. That's part of the value equation for the patient, right? If they say, I'm going to travel anyways to get my surgery done because I'm paying cash and I have a choice of 10 different places, I'd rather go to a place that I can vacation afterwards and be in a new town that's, well populated and whatever. That's an equation that I will never think of for the patient as in terms of their decision making, but it's important to the patient and it's important for them to make the decision, not anybody else sitting around a boardroom.
yeah, and it's exactly, it's like if the cousin that they really like lives close to South Carolina and they wanna go there just to have the support, there's so many factors, that come in. So how do you expand? How does ACEs become like a how do doctors come and say, "Hey, I wanna work with you"? How do you expand into more ASCs? How does this ACEs become like a big national company?
Right. So I do want to become a national company. And I'll tell you, like, obviously finding the different um, pieces and putting the different pieces together, it involves different channels. So I would say we already have enough doctors. There's a lot of people reaching out saying, I want to be part of this team. I would say that is mostly from LinkedIn, just like the professional network, and word of mouth, right? So like some doctors who already work for us telling other doctors like, hey, like you guys have to hear about this. Like this is a pretty cool thing. So, we need doctors, but we already have, I think, more doctors than we can support right now. So we have them kind of waiting in the wings. ASCs need to be convinced that this is a good model. And it's just a matter of reaching out to the ASC at a location where there's enough demand, where we say, hey, you know what, like how much can we lease your OR how much is OR time worth to you? And can we come in and use it? And so that's not an issue. I think the issue right now is just getting our name out so that we get the patients. And so there's a few avenues for that. There's like online marketplaces where employers or patients directly can shop around for the prices, because we're all very transparent. And I will tell you, the people in this business are not shy, and are not like um they've been very receptive to sharing ideas, right? Because we all have our prices listed. Like, I can't charge 3 times what the Surgery Center of Oklahoma charges because nobody will come to me, right? But that's the beauty of competition. That's why when you do open up a free market, that's why the the um the patients will have cheaper prices for better quality, because we all have to compete over price, right? Or quality, right? We might have better quality, and then we'll charge more. But again, it goes back to the value equation. Then the patient has to choose. Do I want to pay less for lower quality or more for higher quality? Or there may not even be a correlation between the two. So there's marketplaces for patients, and we need like third party administrators to basically know that we are a service, that there's more options than just the 5 or 6 brick and mortar ASCs across the US, that we can really open up shop anywhere within a couple weeks. Like we have the formula down, we have the infrastructure to, if you say, hey, I have enough demand where I can, bring you patients every month in Nashville. Okay, we'll go to Nashville every month. We'll set up shop again. We can, and what I want to do is also be multi-specialty. So not just general surgery, which is what I do, but also orthopedic surgery, GYN, ENT, hand. We just got a hand surgeon. Um, it's just, I think the patience is the biggest bottleneck for us now. And there's like some national meetings that we're going to be attending, and just having a booth to make people aware that we're like another Surgery Center of Oklahoma. And our like we're called the National Surgical Team. Underneath, it's direct surgical care everywhere, right? So this is direct surgical care, but we can really be anywhere that the patient is.
So would you go to these like independent, like WellMed, something like independent, large primary care um organizations, and see if you develop a relationship with them?
Yeah, yeah. So direct primary care physicians, and anybody who has a large panel of patients, right? That they see for primary care, that they may have a couple patients that have a hernia that they've been looking for a surgeon for, right? And like in general, I think a lot of those DPCs are referring to traditional hospitals and hospital systems, to surgeons who are using insurance. And again, if they're going to a DPC, there's a very high likelihood that they're cash paying either directly or by their employer. And so we want to target those. So like this weekend, we're going to a conference for mostly DPCs. And then in April, we're going to a conference mostly for like employers, right? So, yeah.
So, in vascular, like Miguel was saying, I see this could work for like venous disease. So, if I meet you at one of these conferences and I say, "Hey, Ronan, I'm interested in doing this in my community. I live in, West Texas, and there's a lot of venous disease, but I think I can set up something cash pay. Can you give me like a really high level breakdown? Or okay, you do this, you do this, you do this. This is how we approach it."
Yeah, it's pretty simple. Your main, you got to basically come up with a competitive price, right? So like you have to shop around to who your competitors are, so you have a lot of vein clinics, right? You have to see, what are their cash prices. You have to come up with what local rates are. You have to come up with, what would people pay. So that's your first, job to make sure that you know what price to do, right? And again, up until a little while ago, there was no market to go out and check what prices should be. Like, if you go to a doctor now and you say, "Hey, what does it cost to see you?" I would say 99.9% of doctors have no idea what it costs, right? So you have to figure out your costs. And then you have to figure out you have to figure out your cost, you have to figure out your price, you have to figure out what the local ASC would want, right? So, so you have to find out like what do they want for cash, and you based on taking all those pieces together, you got to come up with a price that works for you, that you make a margin, and that is reasonable to the patient or their employer who's paying, right? Then you can compare it to what would this cost if I went to the hospital, right? Because that's who you're trying to compete against, really. Um, in the grand scheme of things, right? When we change healthcare, and then you can do this either locally or, like Miguel said, like if you want to get your pilot's license, or if you're willing to fly commercial and provide this care anywhere, then you have to set up a telehealth um, platform. There's some out there commercial that you can use. You have to get licensed in whatever states you're going to work at. You have to get DEAs and all that stuff, and then decide, and also have like relationships with imaging centers. For example, like if you want to get an ultrasound pre-op, right? You got to make sure that for that location, you say, okay, yeah, you have a venous disease. We did a telehealth. I saw what it looks like. Let me make sure that this is not deep disease, right? Like that this is not, something that we got to do something else for before we do the superficial stuff. Um, that's basically it. It's really not a hard formula. Um, and that's why I really am hopeful that this will become ubiquitous, because at the end of the day, when you pay for healthcare this way, every patient will end up paying less. Like you can take home more pay, because you're not going to deduct all the healthcare premiums if you go this route. And same thing with your employer. Your employer will end up saving millions of dollars because they're not paying premiums. And guess what happens when the employer saves millions of dollars? The wages rise also, right? Not necessarily proportionally, right? It doesn't mean like, oh, I'm going to split share everything and whatever. But the truth is, if the employer does well, that's reflected in the wages that they can pay their employees. So this is how to raise, standard of living. This is how to, make healthcare better. It's like a win-win. To me, this is like so simple, you know. And obviously, if people want to reach out, like I'd be more than happy to share. Like I said, I've been very lucky. I went to the Surgery Center of Oklahoma once. I keep in touch with the owner. He's been very good about sharing information. We're not in competition. We're about changing the healthcare landscape.
Yeah, I'd love to talk to him. Maybe we can
Yeah.
have him on the podcast.
Oh
That'd
yeah,
be
he's great. Keith Smith. I can give you his info.
Keith, come
Yeah.
on the pod. So when are you leaving your hospital employed job and going full
uh
on ACEs?
so here's the thing, right? Like so, I trained as a trauma surgeon. I did general surgery in residency, and then I trained as a trauma surgeon. I don't think I'm ever going to leave trauma surgery unless I, win the lottery, right? Or years from now. I'm not ready to leave trauma surgery. And as trauma surgeons will always be
Is there
tied to a hospital.
yeah, is there a lot of penetrating trauma in Williamsport?
Not a lot, not a
Not a
lot.
lot.
But the truth is there isn't penetrating trauma, unless you're in the major cities.
Yeah.
And I'm over it. I've seen enough at Temple,
Yeah.
bringing this full circle. Um, so my goal is for this to expand. Oh, and so going back, like, so as a trauma surgeon, I'm always going to be tied to a hospital. And like, I'm also a big believer that you always should keep the doors open, right? Like, don't close doors. And that if you're a trauma surgeon who doesn't practice trauma for a number of years, you can never get a trauma job. And I always want to be able to have that option. And in order to do that, you still have to take trauma call. So I'm not planning on leaving my job. I just may reduce the amount of time I'm doing it, right? Like,
Yeah.
you know, it's funny. A couple years ago, I thought like I love operating. I want to do this till I'm 70. And then now, I'm 46 now. And a couple years ago, my partner said something to me that really resonated with me, which was, I only have like 10 more years in me. And that resonated with me. And I was like, I'm not even sure I have that much left in me. Like taking
Yeah.
call now at 46,
Mm.
like a 24-hour call is really hard and bouncing back is really hard. When we were residents or like even after fellowship, I could take a 24-hour call and then at the end, like go for a run and a swim, and do errands and then like, crash at like 8 and get a good night's sleep and be back. I'm not like that anymore, and this is not sustainable, right? So, like, uh, again, I'll do trauma surgery, but at a reduced capacity.
Yeah, my life goal is that, surgery becomes my hobby.
Right.
That's my life goal. I love
Right,
surgery. I love it, but it's, everything around it is taxing. Yeah.
well, that's why I feel like, again, if this model expands and you have an option to be a vascular surgeon and just a vascular surgeon without
Mm.
all the paperwork, without all the administrative burden, you would
I
love
could
your life. You would be like,
I
"This is great."
Yeah, I could do it until my 70s for sure. If I could just go into like an outpatient surgery and just walk in, chit chat with the patients, you know, have that interaction, operate,
Right.
listen to music, get a coffee, do that 3 times, 4 times, and then go home by 4, dude,
Yeah.
all day.
Yeah, so that's actually what I've done with ACEs, right? So I have a few surgeons who I help set up this program where, you know, we try to make as little administrative burden on them. And again, because there's no insurance, all they have to do is see the patient pre-op, write a note, go operate, write a post-op note, and see them post-op. That's it. That's all I'm asking for. And they love it because it's what they wanted to do in the first place. And so I'm giving them a way to kind of be autonomous.
Yeah. Let's close it up by I in my philosophy, I had this insight into I went to Burning Man a couple of years ago, and then, when have you ever been?
No.
No, so I went
I don't know if
and
I would survive.
you never know. But so this thing, it's like the desert, and then by 4 days, there's like humongous pieces of art. It's crazy. It's like there's like a solar system, it, all lighted up that just came out of nowhere. And I'm up like I go up to one of the camps that has like a higher up place to view everything, and I'm like, okay, this is exactly what humans are made to do, is to create new things, and to create value in the world by bringing our gifts to reality and by creating. So how does it feel to like, just come up with something out of nothing that could have tremendous impact? Maybe ACES doesn't go like full national, but or maybe it does, but it inspires other people to do it and you create a chain reaction. How does it feel to like have an idea and then it turns into saving patients' lives? It turns into giving people a different way to work where they feel satisfied.
I'll tell you, it feels very surreal, and this goes back to a question that I didn't really answer before, which is, when I started doing the locums, like, out of fellowship, the entity, National Surgical Team, I registered that entity in 2015 because I loved what I was doing back then so much, and I was like, "There is something here that if other surgeons experienced it, they would love it." Even the logo for the company was made in 2015. It's just been sitting dormant until I found the right people to create the business with. And I think that this is important for actually anybody who wants to start a business. It's so important to have a good team around you. And I couldn't have done this until a year ago when I met two very special people, one in marketing and one in business development, who believes in the idea, and we made it happen. But it's very surreal to like just yesterday. So I have these see these airplane models. So those are airplane models of a couple of my airplanes that I've owned over the years. And when we're going to an expo this weekend, and I'm bringing one of those or two of those for our booth, and they come in these fancy cases, and the cases like have the logo on it. And I was staring at the case yesterday, and I was like, holy shit, like this happened, you know, like I made this happen. And it's still surreal, like that you can build, and this is more like for business, that you can come up with an idea that people value. The other thing that I learned doing this was that I, as the physician, am the one holding the value, meaning I could take my skills and go to another state independent of a health system and create value, right? For patients, for doctors, for the ASC, that I'm the one that's holding the value. I'm the intellectual property in this equation. That was a big realization because I think most people who go to med school nowadays don't even know that they can be independent, and they just think, okay, when I get out, I'm going to work for a health system. Well, when we were in medical school, we certainly didn't think that way. And that's part of this. Like, I don't really want to work for somebody else. I want to work for myself.
My experience has been the opposite. I was taught, and maybe it's like a cultural thing, but I was taught to be, a good human. Like to be a good human is to like get a good, like work hard, get a salary, and be of service to people. But like to be a salary and like not be ambitious in that sense, and go create things wasn't like inculcated in me. And it's been
Let
hard.
What did your parents do? What kind of work were your parents in?
My dad was an engineer, my mom was in industrial hygiene, but my dad worked for, like, big pharmaceutical companies doing project management until, like, he didn't obviously goes to corporate America, doesn't like it, and then builds his own thing out of necessity. But I was never encouraged to be an entrepreneur. I was never encouraged, and by entrepreneurs, that's such a, like, overused word, but just to create my own thing. And I never had in my mind that I was gonna go and build my own thing. I had in my mind that I was gonna go work, have a nice title that someone was gonna give me and be, have this position in society that within an organization that would be a hospital or a university or whatever. That was the aspiration. And now, so I quit my job. I'm no longer at the University of Texas. I'm doing locums like you, and I really enjoy it. And I'm planning on building my own thing. But the other day I had a call with like a rep that called me, hey, like I heard like this and this and this, and I just wanted to let you know that I appreciate all the work you do and how you work and how you treat patients and anything I can do to help you. Like let me know. And it was like it's this random guy that I just interacted with, and I know like they tried to develop a relationship, but I got a lot of phone calls from a lot of people, and it's like that cemented that I create value just by showing up and treating humans and doing it in a way where which is the best way I know how to do it. This is the only thing I can do. I can do things the best way I know how to do them, and that is valuable and valuable to people. So all of us all of us hold the value, and all of us hold the cards, and yeah, and be it's
It's funny. It's funny you say that because I see a lot of this on social media. Like, it's like they say, and it's very true. Like, everybody has something to teach other people, something to do for other people. And some people capitalize on it and get it out there, right? Like, get their skills out to other people. And some people like keep it to themselves. And if more people like let it go and like show other people what they can do for them, how they can help them, like the world will be a better place.
yeah. I think, yeah, it's like the book, The Four Agreements, like, we we all have our dreams, and our collective dreams is the world's dream. So I really believe that, by you creating ACEs that, I don't know if that is your dream, but it's how you're expressing what you came into this world to do. And just by that, I don't think you need to be altruistic about it. Just by being true to yourself, you make the world a
Yeah.
better place.
So,
So,
this is exactly the principles of free market, right? Like, and what was his name? Adam Smith, who was one of the first economists, I think this was in the 1400s, wrote that like the baker doesn't make bread to for you to have bread. He makes bread because he values the money that you're going to pay him for it. And the truth is, the world is a better place because the baker makes bread, and the candlestick maker is a better place. Makes the world a better place because he makes candles. So if we all just contribute what we're good at, like you're saying, that's the collective good that comes out of it. That's the collective good that comes out of the free market. And it's a beautiful way to kind of put all this together, right? Because individuals pursuing their own self-interests creates value.
Yeah. I would take it. I think there's something deeper. I forget the name the Greeks had, and there's this amazing podcast called Predictive History. I don't know if you've seen it, but this like Chinese teacher that teaches in this like high level Chinese school that goes over like all like great books, and he was talking about like Greek philosophy, and it's that yeah, the baker wants to make bread because he's interested in providing for his family, but the baker also goes into like a flow state when he's making bread. And he's like takes his nuance and nerds out on the bread because that is his passion, that is his dream. And yes, the money, but in the moment, I don't in the moment when I'm operating, when I'm in the zone, I'm not thinking about money. I'm just thinking of like, I'm gonna put this stitch that way, I'm gonna put this wire that way, and I enjoy every
Yeah,
fucking moment.
you're meticulous about every detail, right? I love it. That's the
That
stuff I
that is
love too. Yeah.
Yeah, that is internal to me as a human. So
Right.
and
And
that
that's
is yeah, and that
and
is
that's what creates
expressed through the
value.
yeah, and that is exactly, and the physical expression of that in the world is the free market, and it's yeah, and I completely agree, but it comes from within, you know?
Right. Like I think
Yeah.
it's amazing that you can like, I say like, most people who go into medicine are like, "Oh, I wanna help people." And I just and they figure out what they wanna do. Like, my thing is, like, it's okay to say, "You know what? I wanted to be a surgeon because I think that's the coolest thing in the world, and I love being meticulous, and I pay attention to the details and all that stuff." And it's amazing that with those things that the standards that I hold myself to, I can help people by
Mhm.
doing that, right?
Yeah.
That's
And the
kinda how I look at it.
act by itself is selfless. Just the act of surgery, obviously, we all love people and we wanna help people, but just the act of it, independent of the human, is selfless, I think. Anyways, Ronan, we'll have you back, buddy. This was
Thank
awesome.
you. This was
All
great.
right.
It was great to see you and talk to you again. Yeah, please keep in touch.
All right, buddy. Have a good one.
Okay. Thanks.